Okay. So, hi, evening, everybody. And hi, Megha. Hi, everybody, bache. Hi, evening, Kishore. And let us just wait for everybody to join in for another 10-15 seconds before we start our today's class. So, just a sec. Let me have a talk with Zainab also. So, okay. So, evening friends, for everybody who has joined. Today it is an integrated session of radiology, and pathology, in which we will be discussing the tumors from head to toe. A very, very important session. Absolutely no doubt about it. And hi, namaste, Ankit. Uh, am I audible and visible to everybody? Please give me a thumbs up if I am. And I'm just waiting for Dr. Zainab to join in. Of course, Tirtha, it is one of the most important sessions for I&I. So finally, Zainab, I hope you with me today.
Hi students, I hope I'm visible and audible.
You are. You are. So let me introduce firstly my ex-student. I guess we know each other for about 6 years.
Yes, we did cross paths in
Close to
between.
that, and one of the most meritorious students, rank one AIMS, rank one NIMANS, broke all the records. After that, we worked together in AIMS for about a year, 2015. Now, close friend and a colleague. So,
And I would like to say it's my pleasure and an honor that I get to share a platform with you. So it's amazing. I'd like to thank Unacademy that it's giving us such nice platforms that we can learn from each other, still learn from each other. So it's amazing.
And a pleasure. So our this session for the students, our this session, we will be covering six classes of tumors in this. That is, we'll start with renal, lung, and the liver tumors. Everybody, for somebody I know, path is slightly on the comfortable side. Radiology is black and white. So for those who are not able to hear us, please refresh it once. For the others, I guess it will be comfortable for everybody. So today we will be taking care in our first session for the three tumors: renal, lung, and liver. An extremely important session. So let us start. Let us start with our first category of tumors, that is the renal tumors. Firstly, let us start with the one-liners. Most common renal tumor in adults. Pink and blue with black and white.
Yeah, that's very nicely put. Actually, we struggled with these four colors during our MBBS, and now we're trying to simplify that for the students. So everybody try and what our aim is to get all of these one-liners out and clear, because this is something which has always been a controversy ever since I think Sir was preparing or I was preparing. These one-liners are something all of us struggle with constantly. So let's just document this once and for all, and this will be beneficial for all of you. So let's start with each one liner. So Sir has come up with a poll, I think, for the first one. So maybe we can do that on poll, and then you guys can answer in the chat box.
So starting with the first one, most common renal tumor in adults. You have these four options, bache: Wilms tumor, RCC, neuroblastoma, yeah, column of Bellini. The most common, agreed. Another 6-7 seconds before we close the poll. I guess this was a much easier question, no doubt about it. Most common renal tumor, most common is RC. Most common renal tumor in adults, RCC, renal cell carcinoma. Next point, most common histological type of RCC. In pathology, if nothing is written before RCC, we mean the clear cell. We mean the clear cell or the conventional type. We mean the clear cell or the conventional type of RCC. Next point, best prognosis. I guess Dr. Zainab, you would like to take over. Best prognosis.
Yeah. Best prognosis. Any student wants to attempt this. What do you think? Best prognosis. Which type of RCC do you think has the best prognosis? This is again something we discuss a lot of times. So there are a lot of histological types. Okay, a few of you think papillary. Right. So Nurel, Tamanna, you are indeed correct. So it is the chromophobe RCC which is supposed to have the best prognosis. All right. So this is a tumor which has a central striate scar. So always remember, this is a tumor with a central striate scar. We'll be discussing this further, but it is something which has the best prognosis. What do you think is the worst prognosis? Anyone wants to take this? Very nice. All of you are perfectly correct. It is indeed the rare type of RCC, which is column of Bellini duct. All right. So it arises from the column of Bellini, or the DCT as we like to call it. And it has the worst prognosis. But if this is not in the option, can you tell me a commoner type which again has a bad prognosis? If this is not there in the option, you have a clear cell, papillary, chromophobe in your options. Very nice. So there it will be clear cell. All right. So remember, in our general garden variety of RCCs, it's clear cell which does have a very bad prognosis. All right.
It is actually opposite to the general rule. Normally, which is usually the tumors which are the most common, like in breast cancer. Most common is ER positive, HER2 negative. That is the best prognosis. Here, the most common histological type, that is the clear cell, is associated with worst prognosis. It is with worst. Next, most common renal tumor in children. I guess pretty straightforward, Wilms tumor. Most common renal tumor in children, that is Wilms tumor. Wilms tumor.
The next one is a tough one. I want to see who can answer the next one. Which is the most common congenital tumor? This is, I am very interested to know who can answer this. This is something which is rare. Obviously, I'm saying this because it's a rare tumor. But what, I mean, a rarely taught tumor. It's obviously the most common one, but something we don't hear a lot. Not angiomyolipoma, not neuroblastoma. Very nice, Lok. So Lok has given the correct answer, which is something we like to call as CMN. So CMN stands for congenital mesoblastic nephroma. All right, so it is something which is the most common congenital renal tumor. Unlike our common train of thought, you would think Wilms tumor hoga, and that would be there in one of your options. But remember, that is not the commonest. All right, it is indeed CMN, which is congenitally most common. So remember this, thoda sa tera mera one-liner that you would like to remember.
Right. Next. So let us actually start with our pink, blues, blacks, and the whites. So starting with, this is where this is the first slide. This is the first slide. You have not missed out anything. So for everybody who have just joined in, bache, for this 1 hour, concentrate not on ma'am, but on the and let us go further. Let us go further. Starting with, we'll be discussing all this in detail. Let us start with our first option, that is first question, that is identify the incorrect pair. I'm again saying this, the main thought process behind this session is not the right or the wrong answer, but to develop your thought process towards solving the questions. Now let us start with the first option. Option A, that is clear cell RCC. Let me zoom it slightly. This does not actually look like clear cell. So this was false. This was false. As we will go further, we will have a look at the tumors. So actually, ma'am, what we can do is let us start with the details of each, and then we'll come to the question and see how.
Yes, we'll come to the question after discussing each one of them in detail.
True. So let us start with our first slide. Ma'am, I'll hand over to you.
Yes. So students who are, not second years, can you tell me what modality this is? Anybody wants to take this? We've been having our daily classes. You've seen a lot of me. So I am very sure all of you can recognize the modalities. Wonderful. So this indeed is a contrast enhanced CT. Those of you are juniors, how do we approach CT and MR? The two usual cross-sectional imaging modalities. Always look at the bones. It's as simple as that. Look at the bones. So here, if you look at the vertebrae, basically, what you will see is the bones are white. So it is CT. Now, how do I know whether it's a contrast enhanced CT or a non-contrast CT? Correct. So look at the vessels, look at the kidney. If kidney is included and it is white, it is again a contrast enhanced CT. If the vessels are white, it's a contrast enhanced CT. Okay, so the basics are out of the picture. Now, let's look at the abnormality. The mass is glaring at you, right? Everybody can see this huge mass which is arising from the right kidney. It's a ball type of lesion. It's a well-defined round lesion. Is it homogeneous? Is it heterogeneous? What do you think? Can I call this a homogeneous mass arising from right kidney or a heterogeneous mass? Good. This is a heterogeneous mass. And can I say it is taking quite a lot of contrast? It is vascular tumor. So 2 points I am getting from this. One, a heterogeneous tumor. Second, it is enhancing. All right. So it is a vascular mass. So these two properties are very, very important in our differentials, basically, when we categorize कौन सा histopathological type है. These two features will favor clear cell RCC. Okay, these go in favor of clear cell RCC. So learning point, a heterogeneous renal mass which is showing vascularity. I will tell you why I'm stressing on this when we see the next tumor. But before that, let's learn the pathology of this. All right, so this is an amazing chance actually for you all to learn the tumors in the same go, because this is medicine, this is surgery, right? What is medicine and surgery at MBBS level? It's nothing but rad and path, in short. I mean, if I can take the liberty to say that. So if you just do all of these tumors in these two classes, I think a lot of your syllabus, of the malignancies will get covered. And definitely expect one question from this, at least one question from these two classes, if not more.
Zainab, I'll slightly interrupt you and I'd like to ask you here, if you have a CCT picture of a patient like this, will you be comfortable putting your signature that this is clear cell RCC? Would you do that? Or would you be slightly...
I'm not comfortable putting the signature or anything. Let me just say that, because we are the worst in terms of medical legal victims, as far as I can say. But even if I had to say, basically, remember, so any RCC, any such heterogeneous mass, if I see, unless mentioned otherwise, it is clear cell. We saw it as the most common type, right? And this is something which is heterogeneous, which is enhancing. So unless I see a specific feature, like we will see that papillary is hypo enhancing, chromophobe has a scar, we will see that. So unless I see specific features of something else, it will be clear cell unless mentioned otherwise. That is how we deal with it.
Perfect.
Okay, and Robinson is asking if the quadroid appearance is seen. No, this is not a quadroid appearance. What happens? We are taking an axial section, correct? So a lot of times we might not go through the core of the bone. We might take a section somewhere between the vertebrae and the disc. So that time it can appear, this grayness can appear. Okay, so that's a very nice observation that you have made. So it can appear like grayish like this. So always make it a habit of looking at the cortex rather than looking at the entire bone. When we are deciding CT versus MR, always look at the cortical bone. All right. Okay, and Avinash is asking if clear cell is mostly unilateral. It is. All renal tumors are mostly unilateral unless they are syndromic. What all syndromes? Again, a very, very important question. We'll be discussing that. Okay? Yeah.
Next, so let us have a look at the microscopic appearance of the same. Microscopically, the minute I see this, I guess it's a beautiful, wonderful, clear white slide. We have the presence of cells in clusters. We are able to see the tumor cells with well-defined margins and a clear cytoplasm. All these are the tumor cells present in clusters with a clear cytoplasm. That is clear cell RCC. That is clear cell RCC. I guess absolutely no confusion over this. Associated with VHL gene mutations. Von Hippel-Lindau, crazy Usha Pragya, totally agreed. Von Hippel-Lindau gene mutations present on chromosome. How many alphabets are there in VHL? 3. So present on chromosome 3. Short arm of chromosome 3. P for petite. Petite is the short arm, chromosome 3P. Next. So this gets us to our next slide. And Zainab, back.
Right. So we are now in the second tumor. So what did I tell you? Clear cell. Our learning was radiologically enhancing mass, heterogeneous mass. It's the बिल्कुल opposite spectrum. Look at this mass here. All right, I'm not able to use my arrow, but yeah, look at this mass. So what we are seeing here is a hypo enhancing mass. Can everybody agree with me? It is not showing a lot of enhancement. It is quite gray, almost comparable to the muscle. Can you agree? So hypo enhancing. Is it homogeneous? Is it heterogeneous? Think back to that picture of clear cell. In contrast, is this homogeneous? Is this heterogeneous? Yes. So this was heterogeneous. See the heterogeneity, white areas, gray areas. In contrast, when I come back to this, it is so smooth, it is so homogeneous, right? Okay, so very nice question by Avinash. You tell me, is this NC, is this CE? So first of all, is this CT? Everybody agrees the bones are white. Is it contrast enhanced? Is it non-contrast? Look at the kidney, look at the vessels, look at the renal vein, aorta, IVC, everything is white. Yes, so this indeed is contrast enhanced CT. All right, so agree, this is CT. All right, and we have a hypo-enhancing homogeneous mass. So these two features, remember, go towards which pathology? It goes towards the type which is papillary RCC. Okay, so radiologically, hypo-enhancing homogeneous mass, papillary RCC. Let's look at the path now.
So when we take a biopsy of the same, or when a section is taken, this is what we are able to see. You are able to make out the presence of papillae. RCC with respect to microscopy, which is pretty straightforward. We have three main variants. The clear cell RCC, where all the cells were clear cytoplasm, well-defined margins, versus papillary RCC, which shows the presence of papillae. The cytoplasm is slightly eosinophilic in nature. Versus when we'll discuss chromophobe RCC, that has a totally different picture. So microscopically, this is papillary RCC. Next.
Okay, so why homogeneous hypotense? I mean, there's no reason as such. All right, it is what the property is. It doesn't take up a lot of vessels. It is just that it's not vascular. That is why it is hypo-enhancing. It is homogeneous. Anything which is hypovascular, remember, there are lesser chances that the tumor can outgrow its vascularity and become necrotic. What gives it heterogeneity is necrosis. Do you agree? So basically, hypervascularity, heterogeneity go kind of hand in hand. Is this concept driven more? So basically, that is why both of them coexist. Right. What does blessed doctor want us to repeat?
The microscopy.
We had both the features together. So in our previous slide, we have both of them rad paths together.
I'll show both the slides together, Nirja. Just a sec, Bachchi. I'll project it for you. Do we have that? No, we do not. Dekho, have a look at this one first. Let us see this. Here the tumor cells were well defined. They had a clear cytoplasm. The tumor cells, they were present in nests with clear white cytoplasm. This was clear cell RCC. Versus have a look at papillary variant now. Have a look at papillary RCC, where you are able to see the presence of papillae. Firstly, secondly, the cytoplasm is eosinophilic in nature. This is papillary RCC. Nirja, that was for you, Bachchi. Next, so this gets us to our next tumor.
Right. Anybody wants to take this?
Zainab, I'll start with first a very basic question on this. Which side is the pathology? Left side of the kidney, it's a renal tumor that we are discussing, left or right? I mean,
right.
Let us start with the
before I can take this, anybody, what side looks abnormal? So students who are junior, first of all right, remember, any radiological modality, it's very simple. Just imagine that it's a person standing opposite to you. All right, so always, basically, if sir can mark it for me.
I marked the wrong answer, I guess, but see, left is right, right is left. So what we see here is this is left and this is right. Always the left is right and right is left.
Just imagine it's a person standing opposite to you. Whether it's an X-ray, it's a CT, it's an MR, the rule remains the same. Okay, yes, for everything, Akshay. And now tell me, is this a contrast enhanced CT, NCCT, MRI? Quickly tell me, guys, what do you think? Yes, this is again a contrast enhanced CT. So a pattern that you are all sensing here. Can you tell me what is the investigation of choice for renal tumors, if I ask you? What all have we been seeing? Only CTs, correct? So remember, it is CECT, which is the investigation of choice for characterization of renal tumors. Now, there is just one twist here. If I ask you staging ke liye, what is the investigation of choice? What is the investigation of choice if I want to stage this RCC? Good. So everybody is saying MRI. Also, it's maybe thoda sa caveat hai. All right. Everything else CT will do the job, except what MRI is better. I have told you guys this. Anybody remembers this? For what particular thing will MRI serve better? Very nice. Sayan, definite. It is indeed the renal vein invasion, IVC invasion, which is again a very big property of these RCCs, correct? Vascular invasion, venous invasion in particular, is something that they very usually do as they go. So for vascular invasion, MRI takes a precedence. It is better. Okay, so remember these thumb rules. Okay, so coming back here, as you have all agreed, the right side has this large tumor. And one of you, Balaji, mentioned, I think, that there is a central striate scar. Correct. So what tumor did I tell you will have a central striate scar in the kidney? Anybody? What is this tumor? Yes, chromophobe. Prognosis, good or bad? Good or bad prognosis? Yes, this was the one we had done, was the best prognosis out of everything. Correct. So remember, chromophobe RCC and as Athena is perfect, oncocytoma. These are two modalities. Oncocytoma, benign. chromophobe RCC, obviously malignant. Both of them appear the same. There is no way as a radiologist I can distinguish the two. Here, I think sir will have a say whether pathologist can distinguish or not. Radiologically, both are the same.
Zainab, we can, and I guess Zainab, we can even tell the students. I guess I might be wrong, but what I'm able to make out here is this is the tumor which is present, and this is the kidney which is being pushed to the side. Can we say that?
Yes, definitely, sir. So this is the tumor which is exophytic, arising from the kidney. So you can even say the origin very, very confidently here, correct? That it's an exophytic, growing out from the kidney.
True.
So do not, basically, sir has brought out a very important point that the entire thing is not the kidney. It's the tumor which is actually the round tumor which is growing out of it.
Next, so when we come to the microscopy of the same, which is this is classical chromophobe RCC. Dekho, chromophobe RCC. Which plant? Now, Anisha, definitely, Usha, you are talking about the presence of a plant cell. What is the main feature that you see? You are able to see the presence of a nucleus with a clear white space around it. That is the perinuclear halo. So chromophobe RCC is associated with perinuclear halo, firstly, and secondly, it also shows the presence of raisin-like nuclei. In pathology, we like the term raisins. So raisin-like nuclei, which is a feature of chromophobe RCC. Next. So
and also, sorry to interrupt, this is something which is asked a lot of times. So this is something which is very important. So one more learning point I just want to drive home is things which are very typical in both our fields, rad and path. Only things which are very, very typical and striking will be asked you. They won't ask you pick up a very rare tumor and ask you. So these things like chromophobe RCC, these appearances, radiological, pathological, both are distinctive. So this automatically, this tumor assumes a lot of importance. Okay, so just remember every time, common things, typical things, ye aana must know hai, whether you know rare things or not.
True. And if we just have to summarize up the three common tumors, that is the clear cell, the papillary, and the chromophobe RCC. As you told us, clear cell was the heterogeneous mass with cystic change versus papillary, which was homogeneous in nature. Next, papillary and chromophobe were homogeneous. Next, I guess radio you will be much more.
Clear cell, as we saw, hyper enhancing, heterogeneous. Papillary, homogeneous, hypo enhancing. Chromophobe, only one thing you have to remember, that it will have a central striate scar. That is all about it. And we can also call that spoke wheel pattern, basically. Same thing. Scar has, so it goes around spoke wheel. Today, only in the liver tumor, I will tell you about one more such tumor. Anybody wants to guess that? What is that liver tumor again?
Let us give them options. Let us give them options actually. Hepatic adenoma. Guys, stop writing. Hepatic adenoma. FNH, HCC, या nodular regenerative hyperplasia. Now,
एक और option add कर दो sir, add fibrolamellar HCC.
Fibrolamellar. I know it is always tough to please a radiologist, no doubt about it. So fibrolamellar variant of.
Remember both liver tumors.
Nan's question is central scar in liver tumor. Central scar is associated with. These are your 5 options. Let me also have a look at the eye. I am not able to see the options. Just a second.
Again, sir, because there are 2 answers, it's fine.
Anyway. I know.
Anyways, I want to.
But anyways, we'll give them the
Yeah.
You are slightly wicked while adding options, I guess.
Right, so 70% are getting this correct.
True. True.
So in the meanwhile, while people are answering, tell me a pancreatic tumor which has a central scar. Let's just take this ahead. What is the pancreatic tumor? Very nice. So it is serous cystadenoma. It is a serous cystadenoma which also has a central striate scar. Will it have calcification in the scar? It does. Yes, it will have a central striate scar with calcification. Okay, I can go on asking questions, but I think the class.
Let's come back. So central striate scar. Next, coming to the cytogenetic aspects of the same. Clear cell RCC, everybody knows, is VHL gene mutation, chromosome 3p. Which are the other tumors associated with VHL gene mutation? I'll like you guys to tell me this also, bache. Which are the other tumors associated with VHL gene mutation? Cerebellar Hemangioblastoma. Keep on saying, keep on writing. Cerebellar Hemangioblastoma. Cerebellar Hemangioblastoma. Next, even pheochromocytoma. Agreed. Cerebellar Hemangioblastoma and pheochromocytoma. These are the two other main tumors associated with VHL gene mutations. Next, papillary RCC is associated with chromosome 7 mutation, trisomy chromosome 7, also called as CMET. Let us add an alphabet, CMET, versus chromophobe RCC. Chromophobe, it is phobic of all the chromosomes. So it is associated with deletions or hypodiploidy. Avinash, hyper nahi bache, this is asked. Deletions or hypodiploidy. Next, folliculin gene, again an important concept. Answer? Zainab, I guess you can take this over.
I have an image, so I think let's go on to the images and then
comfortable. So yeah. This gets us.
Tell me guys, two investigations. First of all, tell me what are the two investigations? Both are the same investigations. Again, our learning point.
I'll start with something more basic. Let us start with the organ first. There are two investigations. Let us start with option A, which is the organ. Your options are brain, thorax. Next, I'll just start the poll. Don't worry, bache. Abdomen, yeah, thighs. So let us start. Which is the abdomen? Which is the organ? Everybody. Agreed. The students are smart, no doubt.
Okay. Indeed, is the brain, and in the brain also, as a lot of you have said, this indeed is the cerebellum. है ना? This is the cerebellum. ऐसे question भी आते exam में, and it's our duty कि ऐसे सवाल गलत ना हो, because ऐसे सवाल गलत होने से कोई नहीं बचा सकता. Even if you answer VHL and get this wrong, फिर कोई नहीं बचा सकता. So this is that learning point. Okay. So what do we have? We have the cerebellum here, which is, as you are all correctly saying, cyst with mural nodule hai. Correct. A lot of you said yes. Very nice, Anisha. So there is a cyst. There is a grey thing outside the enhancing nodule. So ये है cyst with mural nodule. Tell me quickly two differentials. अगर मैं बताऊँ ये child है. This is a child without any renal mass. What will be our differential? Good. I have to think of pilocytic astrocytoma, a grade 1 tumor, right? But if it is an adult and I give you this image, tell me quickly. Go back to your visual memory and tell me कौन सा tumor है ये? Which type? Now you are all equipped to tell me the histopathological type. कौन सा type है? Good. This is clear cell, है ना? So clear cell के साथ when I see this tumor, what I have to think of? I have to think of hemangioblastoma. So this is our cerebellar hemangioblastoma. और add करते हुए क्या बनेगा? दोनों को we have just recalled this VHL. Correct? So von Hippel-Lindau 3PG. And this is it. So this is something which is an expected image-based question that you all must know. Okay? Right. Let's look at one more image. So this is something those of you who have been attending the classes can tell me. First of all, let's go to the renal tumor. Tell me histopathologically कौन सा renal है?
I'll magnify the image slightly for them, I guess.
Do the diagnosis of renal tumor first. Yes. So, right. Very nice. So chromophobe RCC or oncocytoma. Correct. Now let's go to the lung image. Let's go to the lung image and maybe you can tell me what is the diagnosis. Again, an emergency, next to no emergency. Okay, so a lot of you are thinking in a right line, but whenever you are saying tuberous sclerosis, whenever you are saying lymphangioliomyomatosis, guys, क्या renal tumor होना चाहिए? What renal tumor do I expect? Do I expect chromophobe RCC there? Which renal tumor? Yes, then I expect angiomyolipoma. Correct. Renal tumor, agree, but it will be angiomyolipoma. It won't be oncocytoma. So when I have oncocytoma with pneumothorax or lung cyst, and then you have this banda who has these follicular lesions, perifollicular lesions on the nose that we will just see. Tell me the diagnosis. Tell me the diagnosis around the follicles. I am giving you a big hint here. What do you think? Very nice. It is folliculomas, fibrofolliculomas. So where were we having the folliculin gene mutation? Yes, it is the Birt-Hogg-Butte. It is BHD, Birt-Hogg-Butte syndrome. So remember this. This is a potential question for I9. All right. This is something which is Most of you, 50% of the students attempting the paper, they will mark tuberous sclerosis. Like you also saw, a lot of you answered tuberous sclerosis because देखते ही skin lesion, nose lesion, we think of adenomacylation. Correct? So this is something where we have to take a step back and analyze and think to ourselves, is it really tuberous sclerosis or is it something else? Okay, so this is the learning point here. So this is yes, follicular mass, birth of you. Right, sir.
Next, so I guess this takes care of our first category of tumors, that is the liver tumors. Next, this gets us to a second category, that is lung tumors. Let us again start with the one-liners. First easy one. Most common lung malignancy is squamous cell carcinoma, adenocarcinoma, small cell carcinoma, या metastasis. I've just started the poll on the same. Everybody, guys, इसमें तो split होना ही नहीं चाहिए. Today Avinash is enthusiastic and he is writing, but can we trust him for the answer? Most common lung malignancy, बच्चे, is metastasis. Is metastasis. देखो simple funda है. Liver, lung, brain, breast. No, I know the organs are different, but always the most common is metastasis. Most common is metastasis. Please do not forget that. Next, most common primary benign tumor in adults. Primary benign tumor is. Achha.
I give you a hint. Popcorn lesion. HCC. HCC कहाँ से आया? Yes, hematoma.
Hematoma. Next, most common primary malignant tumor in adults. Now we can divide this into India. H नहीं Shweta, S बचे. Now in lungs, actually there's no concept of SCC. I think we should write it as SQ, either squamous or small cell. Firstly, secondly, in India is squamous cell carcinoma versus West, that is adenocarcinoma versus West, that is adeno. Next point. Strongest association with smoking. Strongest association with smoking is small cell carcinoma. Small cell carcinoma followed by squamous cell carcinoma. Followed by squamous. So those of you who have attended my classes, I guess I always say this. Doing everything is okay, but smoking is actually injurious to health. So we can add another point here. Worst prognosis. Worst prognosis is also small cell carcinoma. Worst prognosis, small cell.
So we can also, by extension, if I ask you which is the malignancy which has the highest risk of hematogenous mets, what do you think? Again, so you can remember it on the same lines, right? So worst prognosis, smoking is bad, hematogenous metastasis. So think of them in the same line, all have the same answer.
True. Now this gets us to one of my favorite questions actually. Strongest association was with small cell carcinoma. Which is the most common lung malignancy in smokers? Just two options, squamous cell carcinoma or small cell. Squamous or small cell. Most common lung malignancy in smokers. Everybody bache is squamous cell carcinoma. Totally agreed. This is because squamous cell carcinoma is so common that even though strongest association was with small cell, but most common lung malignancy in smokers, squamous cell carcinoma. Next point. So let us start with our first image. So now just give me one sec. Before we start with this question, let us have a look at a clinical based question on this. That is, you are given this question with the image. Have a look. A 50-year-old non-smoking female is found to have a round lesion in the right upper lobe of her lung. Firstly, next, transthoracic biopsy is scheduled to obtain tissue for histological examination, which would favor the diagnosis of hematoma. Now, unfortunately, in this question, hematoma was already written, but as I will tell, hematoma shows the presence of popcorn calcification. It shows the presence of popcorn calcification. Firstly, image showed you. The question actually does not need an image, Usha. The examiner is asking which one will favor the diagnosis of hematoma. Before we go further, Avinash, हाँ बच्चे, females and non-smokers, adenocarcinoma. Females and non-smokers, adenocarcinoma. Next point. Now, in this case, the answer got slightly split. What is a hematoma? Hematoma, it is disorganized growth indigenous to the site. That is, है तो lung में indigenous to the site. Cartilage is also present in the lung. So cartilage tissue in biopsy sample is a hematoma. On the other hand, alveolar growth pattern without invasion. What would be the diagnosis in this case? This is bronchoalveolar carcinoma. This is bronchoalveolar carcinoma. Next, neuroendocrine markers on electron microscopy would be a feature of small cell carcinoma lung, small cell carcinoma versus squamous pulse in a biopsy sample, which is seen in squamous cell carcinoma. Totally agreed. Totally agreed. Next, Zainab, I'll hand over the screen to you, Bache. So
this was a summary of the histopathological features of all the tumors that we have. So here, this is a very typical exam spotter. So like I said, never to miss simple things, typical things. So this is something all of you recognize. This is a popcorn lesion, correct? So a popcorn lesion with calcification. Agar fat bhi mil jata hai, that's a bonus, correct? It's a hematoma. So it's abnormal tissue here. So fat, cartilage, which we see as calcification basically radiologically, this is a hematoma. All right. So basically, just to again reiterate, this is just amazing. I mean that we can see what it's made up of at a cellular level and then what we see radiologically. So I think this is just a great opportunity for you guys and us also to learn this, because never, like in now after residency, never we learn path, and it was something which was one of my favorite subjects. So this is just, I'm very happy attending this class.
It's very mutual, because finally when I am getting a hang of, the radio path, right? But
right. We have a question. Match the following question for you.
Match the following. So identify the incorrect pair. You have four options. A, B, C, D. If you wish, I cannot enlarge. Do not go wrong in the path related options, guys. ऐसे मत करो. Path वाला वैसे कम गलत है. They do make me. Okay, so the answer is D. Let us start with the questions. Let us start with the images one by one. Starting with the first slide.
So we'll come back to the question again. Let's see each and every pathology one by one, and then we'll. Okay, so again, in lungs, we have various histopathological types that we need to know. So here in this X-ray, can somebody tell me what is the abnormality glaring at you? I'll give you hints. Is it a right central mass? Is it a left central mass, left peripheral mass, right peripheral mass? What do you think? Yes. So as all of you are correctly saying, the left hilum here, right? So everybody, do you understand ki right and left kaise hai? Everybody? Why don't we do it as last time? First discuss the topics and then do the questions. Fine. So basically, see, our main aim with these two sessions is going to be drive home a lot of theory. Okay, that is why we are not doing it as a quiz fashion. We want to teach you as many topics as possible in a rad-path correlation manner. So there won't be many MCQs, but towards the end, after we finish maybe both the classes, we can have a quick quiz for all of you so that it's a quick revision. Okay, that's fine. Right. So what we have here, as all of you are correctly saying, the left-sided hilum is very bulky. It has these irregular margins that you are seeing. So a central mass. Tell me, sir se sound hote hue two malignancies. Two histopathological types which start with the sound sir or maybe the letter S. Yes. So remember, sir for central, sir for small cell, sir for squamous cell. These are again your same train of thought. Right? So two central masses, squamous, small cell. Both of them happen to be associated with smoking, as we saw. Correct? So remember all of these four S's. Atrial myxoma in this. Atrial myxoma will never present like such a large exophytic mass. And atrial myxoma is, remember, definitely it's a very small mass, intra-atrial mass. Okay? It will never project out like this. And so it is very rare for us to have such a large atrial myxoma. Okay? Yes, as for Sushant sir, okay. And what do we have here? Okay, so now we have two central tumors. Okay, a central tumor ke saath, if I add these two images, now tell me what will be the diagnosis? What will be the diagnosis? Central plus these two. Anybody wants to take a guess? Very nice. Now I have to think of small cell. But why small cell? Let's see. So again, if we start with the body part, which body part is this image in? What structure are we looking at? Yes. So as all of you are correctly saying, I am probably looking at an intracranial brain lesion associated with a lung mass. This is likely to be a brain metastasis. On the other hand, in the second CT, CECT, again, do you see the aorta has contrast here? So CECT. Tell me, what are the two abnormalities that we are seeing? Can you see the two bolas on both the sides in the suprarenal location? Very nice. So these are adrenal metastasis. Adrenal metastasis, soch ke remember, what we have to always rule out is a lung malignancy. Right, so lung is the most common site which metastasizes to the adrenals. Very, very typical. Okay, so remember, central tumor, hematogenous mets, small cell. Athena is asking, brain met would be homogeneous. It can be heterogeneous. Basically, this is a non-contrast CT that we are seeing. All right, so that is why it is not. We don't know whether it's homogeneous or heterogeneous. That is why always one of you had asked me today only that why in tumors we give contrast. So the answer is right here to see whether it's necrotic, to see whether it's enhancing or not. So this is NCCT. If I see CCT, then I will see the necrosis. Okay. Yeah. So these. Yes.
So coming to the microscopy, now the minute I see this slide, which microscopically this is the only slide which has been asked twice in the NEET paper. It is a very cellular slide. It is full of cells, but nuclear overlapping is not there. The nuclei, they are not overlapped on each other. Totally agreed. Totally agreed. This shows the presence of nuclear molding. The nuclei, they are molded into each other. They are molded into each other, nuclear molding. You can look at any cluster of your choice. The nuclei are molded, which is a feature of small cell carcinoma lung. Look at any cluster. All this shows nuclear molding, firstly. Secondly, small cell carcinoma lung microscopically shows two features. One is nuclear molding, and the second is Isoparty effect. Second is Isoparty effect. What is Isoparty effect? This is basophilic staining of the vessel wall. Vessel wall, it appears blue in color. Basophilic staining of the vessel wall. Basophilic staining of the vessel wall. This is the vessel wall. How do I know that? Because it is a luminal structure with RBCs in the lumen. Vessel wall should be pink. Here it is blue. Why? Because of entrapment of nuclear material. Occurring because of tumor necrosis. Entrapment of nuclear material occurring because of tumor necrosis. This all which is tumor necrosis. This is tumor necrosis, Isoparty effect. How do I know this is necrosis? Because compare it with normal. This was a viable tumor. This was a viable tumor versus tumor necrosis, which is, this is what it looks like. Next, Rahi, dense core granules is a feature of electron microscopy. That is why on IHC, on immunohistochemistry, small cell carcinoma lung, small cell carcinoma is synaptophysin. It is synaptophysin, chromogranin, and NSE positive, neuron specific NLase positive. Synaptophysin, chromogranin, and NSE positive. This is small cell carcinoma. Next point. This gets us to our next set. So if we have to see everything in totality, I guess I can safely say that this was a central mass which showed the presence of brain metastasis. This was the brain metastasis with adrenal mets and microscopy showing nuclear molding and Isoparty effect. This actually is a beautiful image because you are able to see both the findings in the same image, nuclear molding and Isoparty effect, making this as small cell carcinoma lung. Small cell carcinoma lung. It is the most common associated with paraneoplastic syndromes. Firstly, secondly, just till the answer for my happiness, which is the most common paraneoplastic syndrome is small cell. Hypercalcemia, SIAD. I'm giving you options: hypercalcemia, SIAD, Cushing's syndrome, or Lambert-Eaton syndrome. Your options were hypercalcemia, SIAD. Most common paraneoplastic syndrome with small cell, SIAD, syndrome of inappropriate ADH secretion. Hypercalcemia, on the other hand, is most commonly associated with squamous cell carcinoma. Squamous cell. Large cell carcinoma is associated with large cell. Everything is large. Gynecomastia because of gonadotropin secretions. This was small cell. Before we go further, I'd like to ask you this. Are you guys comfortable with the session? Next, it is tough. Of course, it is tough, but understanding. I'll just start the poll, so don't worry about it. Next, I know. Next, everything is going in the cloud. There's no right answer, so don't worry about that point. But very curious, very curious. Answer.
This is a nice chance to get on top of the leaderboard, by the way. अगर कुछ भी नहीं आता ये सही कर दो.
I know, Shivanki Bache, it is little bit tough, no doubt, but I am glad as long as everybody is in A and B, everybody is in A and B, everything will go well. So this gets us to our next slide.
Right. So remember our central tumors? What were those two tumors which are central? Let's go back. एक हमने कर दिया. Little slow means you want us to be slower or you want us to be faster. What does that mean?
No, she wants us to be slightly slower. I know, Monica.
That means you slow or same pace. Fine. So I'll be slower. Basically, I think that translates to me. So whenever we have a central mass, all right, remember we had two things. Correct. We had two things, which was small cell and squamous cell, right? As you were all saying. So small cell हमने देख लिया hematogenous next. Now with the same central tumor, if I add this feature, what is this feature in this lung mass? Before that, tell me the modality. All of you are comfortable with the modalities now. What is this modality? Yes, it is a CT. It's a contrast enhanced CT. Right? The vessel, the aorta does have some sort of contrast, although it's not very good. Yeah. So basically, as you have all picked out, I think Shayan had answered it. We are seeing the central cavitation. Can you all see these black dots? We know on CT, on X-ray, air is black. Correct? Everybody is comfortable with this. Air hoga kala, black. Okay, as you are seeing in the surrounding lung, also air is quite black, and in the normal lung. So similarly, can you all see these kala foci inside the tumor? All of these black foci, that is air. Anytime air comes inside a tumor, can I say it is cavitating? Okay, so this is basically a central tumor with cavitation. Central tumor plus hematogenous mets translates to small cell. Central tumor with cavitation translates to squamous cell carcinoma. Remember this. Now, let's go on to the second image. See the second image here. Where do you think is the tumor? Right side, left side? Quickly tell me. Although sir has now it is in the left side. All right. Can you tell me upper part of the chest, lower part of the chest? Kahan pe hai? What section is this? Where are we exactly? Lower में नहीं है, upper में है. Remember, see this trachea? Can you see the आगे का U-shaped का trachea? That is your trachea का level. Yes. So remember, basically, this trachea ka level indicates we are at the lung apex. We are quite superior. Scapula, wonderful. Scapula you can see posteriorly. And also, this is something which is at the thoracic inlet or at the superior sulcus. So tell me that category. Very nice, Anisha. So this is basically our pan-post tumor, also called as superior sulcal tumor. Alright, so superior sulcus ka tumor or pan-post tumor. Again, why is this here? This is here because, again, what histopathological type is the most common one for pan-post or superior sulcus tumor? Remember, it is squamous cell. Again, it is again squamous cell CA. There is some bit of controversy here where some people do say that it's small cell, but it's definitely squamous. All right, both of us, it's squamous cell CA basically, which is the most common histopathological type for a pan-post tumor. Now, one question. Again, all of these modalities, what modality have we been seeing for lung CA? Yes, all of you already predicted my question. It is CCT. But for pan-post tumor, we have something else. For pan-post tumor, right, so we can just write it for the juniors here, that CECT. Again, like with RCC, this is the investigation of choice for all the lung tumors, except for pan-post tumor, where we will have MRI. Why MRI? Yes, as Usha has correctly said, it is to rule out involvement of nerves. Remember, guys, again, the general rule, for those of you who are second years also, remember, anything to do with CNS, all right, anything to do with the brain, spinal cord, nerves, PNS, CNS, always MRI will have a higher role. All right, remember this thumb rule. So, because we have the superior sulcus, brachial plexus, subclavian getting involved, we want to basically look at the nerves. So that is why MRI is the investigation of choice for pan-post. Okay, everybody. So this is about squamous cells here. So we have done small cell, we have done squamous, right?
Next, so let us have a look at the microscopy of the same. Now, starting with the gross section, you very well are able to appreciate this is the trachea with the left and the right lung. The mass is huge, so though it is more centrally present as compared to peripheral, but it is huge. The bulk of the mass though is central in location. Firstly, second point, central location for me as a pathologist does not help me much because it can either be squamous or small cell. I will always like to confirm it by histopathological sectioning.
Right.
Now,
Sorry, just step in. If I ask you in this tumor, what would be the route of biopsy? How do you obtain the biopsy? Anyone? How do I get the biopsy? What are the routes that we have to take for biopsy for lung masses? So remember, there are two routes. All right, there are two routes that we can take. One is via bronchoscope, correct? Transbronchial, as you are all saying. We can come via the bronchus. If we see the mass, take a piece of that. Right. The other thing, what if it's a peripheral mass? What if it's a peripheral mass? I can't have my bronchoscope reach up till there. What do I do then? Yes. So remember, the other route for peripheral masses is CT guided biopsy. Okay, not ultrasound. Again, remember, Aditya, as a general rule, ultrasound with lung, with air containing things is a no-no. Alright, जहाँ पे भी air है, ultrasound का role नहीं आएगा. So now we have CT guided biopsy. Alright, CT guided biopsy. There is a theoretical risk that there can be tracking, but for now we want to prove it, correct? What takes precedence is the fact that we want a histopathological diagnosis to treat the patient. So even if there is some theoretical 1%, 0.5% risk of seeding, still we have to do. Okay, so CT guided biopsy for peripheral, for central, like the one you are seeing here, bronchoscopic biopsy. Okay.
Next, with respect to microscopy, I guess this is an absolute spotter. That is easy. You are able to see the presence of tumor cells which are showing invasion. All this is showing invasion with presence of keratin pearls. All this, which are the ones I'm marking with blue, all this are the keratin pearls, clinching the diagnosis of squamous cell carcinoma. These are the keratin pearls, clinching a diagnosis of squamous cell carcinoma. Next. So if we have to summarize the findings, starting with the X-ray of the same, what you see here, what you see in X-ray was the presence of a central mass.
Right. Now it's on the right side. Right. Unlike the others, there's a new X-ray that we are seeing. We have a right-sided mass. Can somebody tell me what sign am I seeing here? So this is something which is a different X-ray from the one we saw. What kind of sign is it creating? Yes, sir is helping you out here. Yes, it is a golden S sign. It is a golden S sign where the central mass has done what? It's gone into the right mainstem bronchus, right upper lobe bronchus, caused the obstruction, leading to the collapse of right upper lobe. So central mass plus a right upper lobe collapse produces this S. Do you see this ulta sa S? This is the golden S sign. All right. So yes, so that's marked here, right upper lobe collapse. And then you have this bulge at the hilum. Can everybody see this bulge at the? So that is the mass. Again, a central mass with cavitation, with keratin pearls. Adding this all together, it comes to squamous cell, and all the points there with you. Yes.
Next, so squamous cell, making this as squamous cell carcinoma. Next, Amit Bache, you need to specify there are two faculties. So,
MSK class will be tomorrow. All right, tomorrow 10 p.m. we have the MSK class.
Okay. With respect to me, I have a session at 10:15 for the FMG segment. So done. Next point. Squamous cell carcinoma. Point to be noted here is the most common paraneoplastic syndrome with squamous cell is hypercalcemia because it is associated with secretion of PTHRP, parathyroid hormone related peptide, PTHRP. Next point.
So that is what we said, na? The pan-post vein is squamous cell, right? That is what we had taught you earlier also. So it's the same basically that is being documented here, right?
True. Next. So
now it's a different kind of image if you see here. Rather than seeing a well-defined gola mass that we were using in kidney, in lung, what are we having here? A very, very ill-defined, if you see this in the left side, in the left middle zone, there's a very ill-defined thing. Okay, so sir, do you want to take Praveen?
Keratin pearls, which is these are the keratin which is being synthesized or secreted by the squamous cells, leading to the formation of keratin pearls. That they signify the squamous origin of the malignancy. Praveen, that was for you.
Right. So again, if we go back to this image, now I'm seeing a very, very nice pulmonary central. It's not hilar mass. Do you see? It's not as central as it was with squamous and small cell. It's somewhere based in the lung. And when I look at the CT here, this is what is called a lung window or a high resolution CT of the lung, because now everything else in the mediastinum, in the chest wall, it's all white. I'm seeing the lung very, very nicely. Can you all see the CT? So this is what we call as high resolution CT. इसमें क्या लग रहा है? Can somebody tell me the diagnosis? If I just see this, भूल जाओ malignancies पढ़ रहा है. What would we call this? These are the black linear structures that you are seeing. These are the bronchi which are patent. And inside the whiteness posteriorly, yes. So these are ground glass opacities, or these are consolidations basically which have air bronchograms. Okay, so these are actually consolidations. Basically, the learning point of this entire story is what? The learning point is that adenocarcinoma. All right, adenocarcinoma can present as consolidations. Okay, we have Nikita ma'am also who's joining us, which is great. So now we have 3 faculty on board. So we have consolidations, all right, as adenocarcinoma. This is something which is a learning point. A lot of times what will happen is these patients will be, will go to the physician with this CT or this X-ray, they'll give antibiotics for pneumonia, कि जाओ ये लो और वापस मत आना, ठीक है? But what will happen? This X-ray will never resolve. All right, this pneumonia, this patch of consolidation, obviously being a malignancy, will never resolve. So remember the phrase, non-resolving consolidation. Non-resolving consolidation, most important differential, adenocarcinoma. Your squamous, your small cell will not do this. Okay, adenocarcinoma will do this where it appears as a peripheral mass. All right, it appears as a peripheral consolidation. Okay, is this clear? So this is a differential of consolidation. Right.
Thanks. So when we see this on microscopy, I guess microscopically, this is again a spotter. The minute I see this, I will neither confuse it with pneumonia or nothing else. I mean, this is classical gland formation. You are able to see the presence of glands. All these are the glands, firstly. Secondly, look at the cells which are lining the glands. They are very dysplastic, very atypical looking, with presence of a prominent nucleoli. There is loss of nuclear polarity. There is loss of nuclear polarity with prominent nucleoli. Loss of nuclear polarity along with prominent nucleoli and gland formation, making this as a case of adenocarcinoma. Making this as adenocarcinoma. Making this as adenocarcinoma. So if we have to summarize all the findings together, in X-ray, we had a ill-defined mass, which on CT showed the presence of consolidations. On microscopy, CT consolidations which are non-resolving by antibiotics, and microscopically shows gland formation with loss of nuclear polarity, making this as adenocarcinoma. Next point, 2 very, very important questions with respect to pathology in adenocarcinoma. First, which is IHC, immunohistochemistry. It is TTF1 positive, thyroid transcription factor 1. Let me write it for you here. TTF1, thyroid transcription factor 1 positive, and napsin A positive. TTF1 and napsin A positive. First point. Second point, molecular markers. I want you guys to tell me this. These are the molecular markers associated KRAS, EGFR, ALK gene mutation. Fair enough. Which is the most common? You have 3 options, 1, 2, 3. Again, an important point. Which is the most common molecular marker associated with adenocarcinoma lung? Most common molecular marker with adenocarcinoma, which is EGFR gene mutation. Whether you remember anything else or not with respect to molecular markers, you do have to know that it is EGFR gene mutation. You also participated in the poll. That is next point. So this gets us just at a summary of the same. Small cell carcinoma, most common paraneoplastic syndrome was CR. For large cell carcinoma, most common paraneoplastic was gynecomastia. Adenocarcinomas are associated with thrombophlebitis versus squamous cell, which is associated with hypercalcemia. These are the paraneoplastic syndromes associated.
Can you tell the syndrome? Sorry, the syndrome that we call it when there is thrombophlebitis. What is the name that we give to this? What is the name? Yes, it is the Prognosis syndrome. And tell me one more malignancy that can cause this in the abdomen. Good. So pancreatic CA, adeno-CA are notorious for causing this malignant thrombophlebitis.
Right. I guess it was last year's mid-year exam question. Prognosis syndrome is associated with pancreatic. Done. Next point. So this gets us to our last set of tumors. We are done with weren't we done with liver?
What? Sorry, sir?
No, my mistake. Okay, so this gets us to our last set, that is liver tumors. Athena knows when I started.
Avinash is asking if Lardel will show chromogranin and synaptophysin. Sir, you want to take that?
Cell also. Avinash, nahi bache, nahi. When we talk of classically chromogranin and synaptophysin positivity, we are talking of small cell carcinoma. Large cell carcinoma, this statement is very, very important. Large cell carcinoma is a diagnosis of exclusion. It is a diagnosis of exclusion. Even after doing a biopsy, if we are, if I'm able to see large cells or something, I will not jump onto the diagnosis of large cell. I will rule out others before signing it out as large cell. It is not synaptochromo positive. Avinash, no.
Right. Same. Radiologically also, Usha. So basically, they do not have any specific feature. Why have we completely ignored large cell in our discussion also is because uska kuch specific hai nahi, nothing to remember. I mean, it's always a histological diagnosis as far as we are concerned. We can never say ye large cell lag raha hai. All right. Other malignancies, maybe we can go out of our way. In the question, there was a CT image. No, so that was the wrong answer. Maybe, sir, we can now have the MCQ that we had shown and see how many of you remember.
Yes, just a sec. I'll go back to
lung question. Maybe we can start now. That is what.
Let's start with the renal. I had marked the answer already. So let us start with lung. Unfortunately.
Okay.
Now अगर अब 100% आंसर नहीं आए, so अब गड़बड़ नहीं होनी चाहिए, no doubt.
Okay, सब जाग रहे हैं.
Yes. So the answer was D. What was D as such? बच्चे, what is the diagnosis in D? Can you please tell that?
So now, okay, this is something which is a twisted question. Tell me the modality now. What is the modality that I'm showing you now? Good. So as all of you are saying pan post, remember we had done investigation of choice for pan post was MRI. इसी पे हमने MRI किसमें D में.
Praveen D में.
The bones are not white. It's a sagittal image. All right. Again, when you look at it in a zoom manner, it might not make sense, but we have taken a sagittal cut. So, upper, can you all see this? Make out this mass which is there. Upper and then niche, you can see the black lung. Everybody. So this is a sagittal section, and again you see it's a superior tumor. And it's a tumor which is extending in the lung apex. It's a tumor which is in the superior sulcus. So this is the Pancoast tumor. Yahi pe brachial plexus hai. This is where a brachial plexus lies. That is why I want to do MRI to see that invasion of the nerves. Okay. All right. Just a quick difficult question for you. Pancoast tumor. Tell me the minimum stage. Even without any sort of extension, what is the stage that it always has to be? Not T4. See, remember in lung staging, just one line remember that anytime there is chest wall invasion, it is T3. It is T3. Alright, so remember, ये तो chest wall का ही tumor है. It is arising from the superior sulcus. Can you see here how it's affecting the ribs? It's going between the ribs. It's a chest wall tumor. So always remember, just an important or a difficult one-liner, always minimum इसका invasion होगा T3. Alright, the stage will be T3 because it always invades the chest wall. Right? Okay.
Next. So there was a question whether we are able to see gland formation. Athena, bache, the option C, you are able to see. I am not very much interested in the microscopy of this in this session, but you are able to see the presence of mucus cells which are spreading. which are spreading along the alveoli, making this as adenocarcinoma. So option C was
lipidic spread. You can see along
lipidic
the
spread. So actually this was PGI question, and we'll have a separate half-an-hour session of the variants of adenocarcinoma in that.
So basically, just to tell you the extension of it radiologically, you see how it's spreading along the alveolar septa, right? That is why it looks like a consolidation. Because while it's growing along the alveolar septum, it's making a consolidation. It's involving all the alveoli. All right, so basically see the correlation again, how it's lipidically spreading and how it's looking radiologically.
True. Next, so this gets us to our last section for today, that is liver tumors. So let us start with the one-liners. Most common, very easy. Please don't write anything. I'm starting the poll. Is HCC, hepatocellular carcinoma, hepatoblastoma, metastasis, Wilms tumor. Most common liver tumor. Most common. Bache, I have no idea why you were thinking of Wilms tumor on this. Wilms tumor is a tumor of the kidney. Most common liver tumor, again, metastasis. Please do not forget metastasis now. Most common liver tumor, metastasis. Next point, most common primary benign liver tumor. So now please note the further 4 questions, they have the word primary in it. So most common primary benign liver tumor is a hemangioma.
A lot of you are saying adenoma. Remember, adenoma is not the most common. It's actually hemangioma, which is the most common. Right? After hemangioma, you have adenoma.
Agree. Next, Usha, I thought it was third. But anyways, bottom line is most common is metastasis. Next point, most common primary malignant liver tumor, HCC. That was easy and a no-brainer. HCC versus primary benign liver tumor in children is bache IHH.
Benign. A lot of think hepatoblastoma, is that a benign tumor? Blastoma, anytime you have the word blast, it is not benign, it's malignant, right? So yes, again, remember hemangioma only. This is infantile hepatic hemangioma or IHH. Its earlier name. A lot of you must be familiar with its older name when it was called infantile hemangioendothelioma. Okay, but the new nomenclature is now IH, infantile hepatic hemangioma.
And last is someone agreed malignant was hepatoblastoma. Totally agreed, Bachi. Totally agreed is hepatoblastoma. Next point. So this starts us with our first image. Identify, we'll do the MCQ in the end in this.
Let's do this at the end.
Let's do the MCQ in the end. Let us start with UMA.
Right. So basically, so far in kidney and lung, we saw CECT was taking a very, very big role, right? Except for certain indications. In all liver tumors, remember as a general rule, what investigation we would do is something which is triple phase. Very nice. So it's always triple phase. It can be a triple phase CT or a triple phase MRI. Both are used in conjunction. If you have to choose one, go for triple phase MRI as the investigation of choice. Although they will not ask you this question, but if they do, MRI will have a better role than CT because again, when we are doing triple phase, it means that, what does it mean? So triple phase ka matlab hai, I give IV contrast, correct? They are injecting IV contrast. I take 3 phases. One is the arterial phase. Okay. As the name suggests, arterial phase means it will be an early phase. As soon as I inject contrast, the contrast goes in the arteries, it is seen. So this is the early arterial phase. The second phase, when all the vessels get the blood, artery bhi mil jayega, vein bhi mil jayega. That is the venous phase. Okay, that is the venous phase. And the third phase, which I do, is a delayed phase. Alright, delayed phase is done somewhere around 3 minutes. Okay, so this is done to characterize the mass. You all know liver has dual blood supply. It has arterial supply. It has venous supply. Agree? Hepatic artery also gives blood. Portal vein also gives blood. So basically what happens is normal liver gets maximum supply from the portal vein. Remember this concept. You understand, Bharat? It's very important. Okay, so normally most of the liver will get blood from the portal vein. Correct? Whereas remember HCC, hepatocellular carcinoma, tumors take up blood preferentially from the arteries. Okay, they take up blood from the arteries. So I want to see that distinction. कि जो mass early arterial enhancement show कर रहा है, which is getting arterial supply. Okay, That is basically something I want to pick. So that is why we are doing a triple phase. Yes, I hope everybody understood this concept of why triple phase. Everywhere I was not saying कि दो तीन phase करना है. I was saying एक CCT करना है. Correct. So remember, this is triple phase. Now, why am I saying MRI is better than CT? Remember, CT has radiation. Like all of us know that. First years to final years, CT has radiation. Now, if I want to do radiation 3 times, what would you prefer? If you were the patient, would you prefer कि 3 बार radiation लगे, or I do a non-ionizing modality like MRI if it is available? Obviously, MRI would be better because MRI no ionizing radiation. Okay, so that is why it is better. Okay, so that is the learning point. Okay, so now going back to the previous image, everywhere now in the renal liver masses, you will see I will show either 2 or 3 phases which will help in the diagnosis. Okay, so now everybody agrees that bone white hai, so it is a CT, right? And now see the first image, see the very, very white structure. Can you see just anterior to the vertebrae, बहुत ही white गोला है. What is that vessel? Anyone? Good. It is the abdominal aorta. It's the aorta. So now you see aorta has so much contrast. Can you all agree with me and identify that this is the arterial phase? Aorta has so much contrast. It's so white. Okay. So now see the liver tumor that sir has marked for you. Do you see how it is getting this peripheral nodular enhancement? Peripheral nodular sa enhancement hai sabko dikha hai? Yes. Now we go to the second phase. See the second image that you have. Now see the colors. Aorta ka color light ho gaya. Vein has gotten all the blood. See the IVC just next to the aorta, you have the vein. So that is now a venous phase. Yes, this is basically the venous phase that you have. All right, so now in venous phase, what happened to that lesion? Do you see how white, completely filled up it has gotten? Can you all appreciate कि जो periphery में था, now has gotten centripetal filling in. Can I say centripetally अंदर कर रहा है बाहर से? So centripetal filling in of a tumor which was showing peripheral arterial enhancement. This is very, very typical for what lesion? Tell me the diagnosis now. Tell me the diagnosis. Anybody? I'll give you a hint. Pathologically, इसमें blood pool है. It has this swimming pool of blood. So blood is coming from the periphery and going in and staying inside. As you can see, arterial phase में blood आया. In the venous, it is constantly coming and swimming there. The contrast is also swimming there. Yes. So this is hemangioma. All right. So again, such a nice correlation of what you see at a cellular level and what you see at a radiological level. Yeah. So,
agreed. Acha, tell me this. Can we do a FNAC? FNAC can be performed in cases of hemangioma, or FNAC is diagnostic. By mistake, I marked the wrong answer. Don't worry about the answer. That is marked. But can we do a FNAC? We cannot. We cannot. False. Majority of you are right, bache. We cannot do an FNAC because when an FNAC is performed, it will show me nothing but blood. So I will not be sure whether it was an inadequate aspirate, the cells were extracted or not. Because thing is that even if Dr. Zainab tells us, Sushant, don't worry, sign it out as hemangioma, I'll be, very dicey while signing out hemangioma on a pathology report, especially on an FNAC. So FNAC is not preferred for hemangiomas. Next.
Again, this is something, tell me the modality, guys, tell me what investigation are we seeing here? Good, very nice. So this is MRI. Okay, this is MRI. See the bones now. See the bones, they are black. The bones are black. So everybody is correct. This indeed is MR. Can somebody tell me what sequence? T1, T2. I mean, the junior guys, it's okay if you don't know the sequences, but I see a lot of my students. So tell me, is it T1 and T2? Yeah, it indeed is T2. Correct. You are seeing where do we look for in T2? I look at the spinal canal. Correct. Water is white. Water is not black. See the spinal cord ke around ka fluid. Everybody is thin rim. This is basically your CSF, which is white. Now tell me a completely large white tumor. What do I call it? Can I call this something like a light bulb? Is this looking like a light bulb? So white, correct, glowing like a light bulb. So this light bulb lesion, this is a one-liner which your examiners love to ask you. This is hemangioma. So hemangioma on MRI, very typical. Light bulb. Okay, tell me one more tumor very, very quickly which has light bulb in the vicinity, in the suprarenal location. Good. It is pheochromocytoma. Right? So 2 light bulb lesions. Hemangioma ho gaya, pheo ho gaya. So this is all you need to know about hemangioma. Arterial phase, peripheral filling in, and then it comes in the center. And MRI it will show light bulb.
Light bulb appearance. Agreed. Next, With respect to the microscopy of the same, again a very straightforward thing, because you are able to see the presence of numerous blood vessels which are filled with RBCs. So all these are the cavernous hemangioma. This is a straightforward diagnosis of cavernous hemangioma. Cavernous hemangioma. Next. So this gets us to our next one. So the first that we saw was the most common benign liver tumor, hemangioma. Next.
So what time is your class? Like, do you want to stop because we've extended our time?
Let us do this slide because Hannah, let's do this.
Okay. Let's finish the benign ones. I think we have two benign, so let's finish benign and then we continue with two malignant ones. Okay, so here we have an ultrasound image. This is a Doppler image, right? So every time on ultrasound, you have this color that you are seeing, very nice energy. This is a Doppler. Can somebody tell me, in this entire box, you are seeing a round region. How is the Doppler ka image pattern? Can you see it's radiating from the center? Can I call this a spoke wheel pattern? Can I call this spoke wheel? So it's coming from the center, going as a spoke wheel, right? So remember, tell me a tumor of the kidney which showed this spoke wheel pattern. Aaj hi padha hai. What was the tumor? Central stellate scar, spoke wheel pattern. Good. Oncocytoma या chromophobe RCC, best prognosis. ठीक है. So now we are on to the liver counterpart of that. Okay, so a liver tumor which a central stellate scar with a basically spoke wheel pattern. Very nice. So let's look at the one more image of this. In the next slide, we have the MRI. So let's see that also. Yeah, so here basically you have a tumor. It's a kind of a difficult image, but anybody wants to take this?
I'll slightly stop you because, you know, the minute I saw this image, this white structure popped up. So this extreme white structure is I like most, because as a pathologist of after 10 years I can identify this. So
that means that this is something which everybody must know.
Yes, no doubt. Let me give you options on this actually. Spleen, gallbladder, pancreas, small intestine. Spleen, gallbladder, pancreas, small intestine. This is the most conspicuous structure. I would not have interpreted otherwise. Agreed, bache. This is gallbladder.
Yeah. So again, now tell me by extension, कि ये कौन सा sequence? What sequence is this? Gallbladder, fluid containing structure is white. Very nice. So I hope everybody is following. Even the junior guys in the class are following T1, T2 थोड़ा सा कि water white है तो T2 है बस. World War II. If water is white, it is T2. That is your learning point from radiology, even if you didn't learn anything. Okay, so basically what we are seeing is a mass. Again, see the mass here, thoda sa difficult to identify, but sir, if you can help them, yes. So this is the mass that sir has encircled. In the center, can you see a scar, a differential whiteness? So can I say that there is a T2 hyper intense scar? Will you all agree with me? Hyper intense. Mane white on MRI. Okay, so T2 hyper intense scar with a spoke wheel pattern. Remember, what will be the diagnosis? It will be FNH. All right, FNH, fibrous nodular hyperplasia. Two tumors in the liver with central stellate scar. One is FNH. Second one is fibrolamellar HCC. Very nice, Anisha. Fibrolamellar HCC. How do we distinguish the two? Let's learn it right away and get done with it. So we have FNH, we have fibrolamellar HCC. Fibrolamellar HCC का scar will be what? It will be T2 hypo. Correct? FNH का hyper था, इसका T2 hypo हो जाएगा. And what else will it have in addition? Very nice. It will have calcification. It will have calcification. Okay, so two learning points here. Liver के दो tumors with scar. Fibrolamellar HCC, calcification, T2 hypo. FNH, T2 hyper. Everybody following this? So here in the images that we saw, Doppler spoke wheel pattern of vessels. MRI, T2 hyper intense scar. That is all you have to know from radiology side. Just one thing from nuclear medicine side. Tell me what investigation will help in distinguishing the two. There is a scan called Technetium 99, very nice. Sulphur colloid scan. Tell me, कौन सा uptake show करेगा? Will it be FNH? Will it be fibrolamellar HCC? Which will show uptake? Very good. Remember, FNH pathologically has the Kupffer cells. Okay, so these Kupffer cells will take up this sulfur colloid. That is why FNH shows a hot spot. If they ask you, this is a repeat NEET question. Which liver tumor shows a hot spot on technetium 99 sulfur colloid? Answer will be FNH.
Next. So I guess this gets us to our almost the last benign slide in liver. This is a gross section. Now the minute I see this, I'm able to make out, bache, that this is the well-defined mass. This is the well-defined mass showing the presence of a central stellate scar. As a pathologist, though I will always take sections on this, but this much, the gross identification of this is sufficient for me to call it as FNH, though I will always confirm it on microscopy or biopsy. So this takes care of our today's session. With respect to today, what we are left with are the liver malignancies, which we will take care of the liver malignancies in our tomorrow's session. And before we wrap up, I guess it was actually fun, ma'am, having you here and interacting with everybody.
Yeah, it was great. I mean, we should do this a lot of times, and this was great. I mean, I don't have to talk much. You don't have to talk much. We get our breaks, and we get to learn our respective subjects. So that's amazing.
True. And radio actually was black and white, but it has become slightly better with Dr. Zainab with us.
Thank you so much. The same with blue and pink, although lots more to learn from you, but it was
True.
great.
And Bache, our next session will be tomorrow, 7 p.m. That is, we will start with malignancies of the liver. After that, we'll go to prostate. Very, very important, because you had a question on prostate Gleason scoring, radiology, and everything, even in this mid-year June paper. Prostate, abdominal pediatric tumors, and CNS tumors. The session is tomorrow at 7 p.m. So take care. Leaderboard, I forgot that. So please mark the answer as A for leaderboard to be out. And a pleasure interacting with everybody. But normally when Peeta and Savannah ask this, they are usually, on the top. So,
Maybe 2% have given B.
true. वो तो चलता है. We guys don't believe in.
To keep the competition fair, उन्होंने sacrifice किया अपने rank.
True. But so Bache, this is, see, I told you, Savannah. So, but everybody did extremely well. So take care. Good night, and good night to you.
Thank you guys. Bye bye. Good night.
Bye bye. Take care.